clinical psychology, and public health. This is what we do. Our group provides training and support in the conceptualization of digital mental health interventions, consultation on the development of research projects involving technology, and conducting studies that involve creative use of digital platform to improve access to mental health. WADMA participation is open to all career levels, including students and professionals interested in digital mental health research. This could include mental health professionals, computer scientists, user experience designers, and other people. We have 3 tiers of participation for interested individuals. The first is WADMA network. This will be the most common level of participation to include all individuals who attend multiple events per year and opt in to our mailing list. The next level is WADMA professionals. This will be a more specialized group that includes those with professional skills or accreditation that is relevant to contribute to digital mental health research. For example, clinical practice, technical design, software coding, and so on. We are open to being collaborators on research projects in the region. The last level of participation will be WADMA scholars. This will be a small group of dedicated trainees who specialize in embarking, who has a vision of embarking on careers that are dedicated to digital mental health research. Participation as a WADMA scholar will involve a 2-way commitment whereby scholars produce tangible research products in collaboration with mentors from the WADMA team. WADMA scholars will be selected through a competitive process and will participate in a mentorship program. We are outlining more specific details about this program, which you'll be able to access in our website very soon. I thank you all for coming. Please sit back and enjoy the program. Thank you.
Thank you, Dr. Kola. Hi, everyone. My name is Anna Larson, and I'm a member of the WADMA team. It's my pleasure to introduce our speakers for today, and I'll introduce them in order that they'll be presenting. Dr. Dror Ben-Zeev is a professor of psychiatry and behavioral sciences at the University of Washington and a licensed clinical psychologist who specializes in development and evaluation of technology-based approaches to study, assess, and treat severe mental illness. He serves as the co-director of the University of Washington's Behavioral Research and Technology and Engineering Center. And Dr. Ben-Zeev has extensive experience conducting technology-based mental health research in a variety of settings, including community settings, psychiatric inpatient units, and outpatient clinics. He's led or co-led highly innovative mobile health innovations, including developing the first smartphone intervention for schizophrenia, and has current projects in the United States, Jordan, and Ghana. Dr. Angela Ofori-Atta is an associate professor at the University of Ghana Medical School, where she teaches medical psychology and clerkships in clinical psychiatry. She was the co-principal investigator for Ghana on the Mental Health and Poverty Project, which set up a mental health information system for a psychiatric hospital. She's also integral, or was integral in actively advocating for the passage of Ghana's mental health law, passed in 2012, and she also helped establish interagency collaborative district mental health teams and activated the Psych Corps. Drs. Ben-Zeev and Ofori-Atta co-lead a program of research testing a model for improving care of people with serious mental illness who are receiving treatment in prayer camp settings that incorporates nurse-delivered pharmacopsychiatry and also a digital app which provides psychological treatment via traditional healers in settings around Accra and Ghana. So welcome everyone, and I will pass the mic off to Dr. Ben-Zeev.
Hi, everyone. I will just grab the screen here. Okay. I assume everyone can see this. If not, I'm in presenter mode, so hopefully you'll speak up and I'll know if you can't. So good morning, good afternoon, good evening, depending on where you are throughout the world. We're really excited to have you participate in one of our WADMA talks. We hope to have many more of these in the future. But more importantly, we're looking for opportunities to connect with investigators and aspiring investigators, particularly in West Africa, who are interested in digital mental health. So please view this as an invitation to engage and to try to connect with a network to establish collaborations that hopefully will proceed years into the future. That is really part of our mission as part of this network. But today I'll talk to you a little bit about my history as a digital mental health researcher and how that has led to the wonderful collaboration that I have with Dr. Ofori-Atta and the team at the University of Ghana and with Dr. Kola as well and others in West Africa. Quick slide of disclosures. As part of my digital mental health research, I also have various partnerships and collaborations with industry, and I think it's important to disclose those. But let's start, like with any good story, let's start with my origin story. So it's important to note that I'm not a computer scientist. I'm not an electrical engineer. I don't really have a STEM background. I'm a clinical psychologist by training. And I stumbled into the area of digital mental health almost accidentally. And the reason that I describe this origin story is because I think that sometimes the use of technology can be a little bit daunting to people who don't have those backgrounds. And if a technophobe like me could have wound up in this area through partnerships and collaborations, I think a lot of people with clinical backgrounds, social work backgrounds, nursing backgrounds, services backgrounds can also find their way into this area. There is no formal, well-established training in digital mental health as part of doctoral or graduate school training. So anyone who really works in this field always comes from some other discipline, and they find partners and collaborations over time to do this work. And we'll revisit that, I think, a little bit later in the discussion. So I started as a graduate student in clinical psychology. I was very interested in the way that people with depression remembered their day-to-day experience, right? So when they come into a clinic, and as therapists, we ask them, how has your week been? Is that report that they give us really accurate, or does it reflect other things that are going on that we know that might be linked to the biases and cognitive distortions that sometimes people with major depressive disorder experience? And so I wanted to test this empirically. And the way that I went about doing this is by giving them a mobile device. The cutting edge technology at the time was a Palm Pilot. And I imagine that most of the audience is probably unfamiliar with these. These are the precursors to what we know as smartphones today. It was a microcomputer, didn't really have wireless connectivity to anything, and we didn't have the same wireless networks that we have today. But it was a small computer that integrated prompting and the ability to administer assessments to people. That's really what I was after as part of my doctoral dissertation. I would give my research participants with clinical depression this mobile device to carry with them for a week of data collection. It would ping them multiple times throughout the day, asking them questions like, how sad are you right now? How anxious are you? Who's around you? So questions about mood and context. And then at the end of the week, they would come back to our lab and they would return the device and we would get the data and we would compensate the research participants. And as this study was going on, something very interesting and very surprising happened. as research participants with depression came back to our lab to return the device, they would often say things like, "Thanks, doc, this really helped me. Thanks for being there for me. It was really reassuring to know that you're there in the background caring about me." Now, I say that this is surprising and really quite a bit startling at the time because it really wasn't my intention to help at all. That was not the objective of the study. It wasn't meant to be a clinical intervention. Really, the whole premise of this approach was that we give them the mobile devices and we serve as this unobtrusive fly on the wall, just collecting data, certainly not with the intention of changing their mood. In fact, changing our research participants' mood for the better, anecdotally at least, is counterproductive for that study, right? Because it's really not going to represent what would have been their naturally occurring mood. So on the one hand, from a study perspective, this wasn't a good outcome methodologically because we inadvertently affected people's moods. But from a clinical perspective, wearing my clinician hat on, I couldn't help but think that if we are able to get these reports about people feeling better as a result of interacting with a mobile device that really didn't do much beyond just asking them questions throughout the day at the time, well, what if we actually put our minds to it? What if we intentionally create programs that are designed to improve people's mood, that are designed to help people develop skill sets and strategies to cope with their mental illness, and on and on. And so flash forward 20 or so years now later, that is what I've dedicated my career to. And that's what we do at the center that I lead at the University of Washington. And so right around the time that I discovered mobile technologies, so did the rest of the planet, really. So this was the heyday of the emergence of mobile phones worldwide and mobile cellular infrastructure. And as many of you in Ghana and other areas in West Africa know, the introduction of mobile cellular infrastructure, cell towers, and the capacity to reach people where there may not be landline capabilities has really been a game changer in terms of access to information and to communication. From a public health perspective, it's a game-changing opportunity. So for the first time, we are able to reach people in real time and in real place, and they are able to reach us or able to reach resources in a way that is really not constrained by brick and mortar clinics or distance from a local clinic. And so if we wrap our minds around that for a moment, that opens the doors to intervention, assessment, and monitoring opportunities that were just impossible a few years ago. And so we were all alive to witness the fastest adoption of technology in human history. And to put some numbers behind that, these are the estimates of the UN's telecommunications unit, their unit that's focused on evaluating technology. If in 2001, there were approximately 1 billion mobile cellular subscribers worldwide, well, right around the end of 2017, the number of mobile phone subscriptions actually caught up and exceeded the population on the planet, right? So what that means, and especially when we look at this at a breakdown by region, we see that the vast majority, especially of the adult population on the planet, has access to a mobile device that can send and receive information using mobile cellular infrastructure. And these numbers hold, there are of course regional changes, but by and large, the numbers hold across regions and increasingly more across socioeconomic status as the cost of devices and of data plans continue to drop. Okay, so all this is the backdrop for this area of digital mental health, which we're focused on with the WADMA network. And I think here it's probably useful to provide some definitions because people use these terms differently. And sometimes we all mean the same thing, and sometimes we mean different things. And so to help clarify some of the terminology, start with what digital mental health is. Really, what we're referring to is the use of digital technologies in mental health research or in mental health services. And so what that means is that we might use mobile digital technologies or other digital technologies in the study, assessment, treatment, ongoing clinical monitoring or attempts at prevention of mental health problems. That's the application of that. And so a term that's often used and is almost synonymous with digital mental health is mobile health or mHealth. Mobile health refers to using mobile technology specifically for digital mental health purposes. And a mobile technology can be anything from a simple cell phone to a smartphone to a tablet, anything that does not require wired connectivity to resources. Increasingly, more and more of what we're able to do in the digital mental health space is in fact mobile health, because most things are accessible now through software that's accessible on a mobile device. There are also terms like electronic health or e-health, and many of you might be familiar with the term telehealth or telemedicine or telepsychiatry. Really, this is just the ability to deliver this healthcare remotely, and usually that is facilitated by digital technologies. Another term that's closely related is health IT or HIT. Health IT overlaps to some extent, but really refers to the processing, storage, and exchange of health information in any type of electronic environment, right? So certainly mobile health or digital mental health can take advantage of health IT, health information technologies. And so what is mHealth? mHealth can mean anything from using specialty smartphone apps, wearable devices, fitness trackers, sleep trackers that are placed on the body. Over the last few years, we're seeing more and more use of terms like digital therapeutics, which refer to interventions that have evidence supporting their clinical utility and effectiveness. And in the US, increasingly more and more, there's a push towards having FDA regulation and using this term to monitor and regulate devices that are digital therapeutics versus wellness apps, for example. But mHealth can also be things like augmented and virtual reality programs, right, that intersect with some sort of clinical intentionality. When we talk about health information technology, this is when we think about things like electronic health records, e-faxing, encrypted email that might be used to communicate about patient data, secure texting and patient messaging platforms, and video conferencing, right? So Zoom, for example, or if we use Microsoft Teams or other resources to communicate in real time, all that, if we're talking about patient care and healthcare, falls in the domain of health information technology. So that's just to give a bit of a framing of what are the terms that we use in this area. We dedicate a lot of time to this research and work at our Bright Center at the University of Washington, located in Seattle, for those of you who are not familiar, and at Washington, D.C., but on the entirely other coast of the United States. So how do we think about using mobile technology, mHealth, for mental health care at the Bright Center? Well, really, there are increasingly technologically sophisticated approaches to do this that almost evolve as the technology itself evolves over time. In its simplest form, we create interventions that just facilitate person-to-person interactions. So you have a live clinician, a peer, a caregiver, or a family member with some form of expertise or content that they want to communicate to someone, and a patient or a recipient of this information, and the technology really just facilitates that connection remotely. And so that's where you might have interventions that are based on phone calls or text messages between a live person and another live person. There are also mobile health approaches that involve more sophisticated technology, and that's when we get into the area of sensing or applications of natural language processing to data that's collected using these devices. And so by sensing, we might mean data collection like GPS, audio, visual information using sensors, the host of sensors that are based on someone's smartphone on our wearable technology. And natural language processing refers to the programs that we use to extract information from verbal data. So that can be spoken language, it can be text messages, it can be transcribed, and there's a host of things that now we can do, especially with applications of language models, and more people talk about AI and LLM, or large language model applications for this, using patient data in healthcare. And I'll provide examples for all of these shortly. And another frontier is when, unlike that first step in that evolutionary ladder of technology sophistication, we move towards automated interventions. This is when we really increasingly remove the provider from the loop. And some of these interventions, like smartphone applications, where a patient might interact with it entirely autonomously. And I'll provide examples for that in a moment. The idea there is that in areas where we might not have access to professionals, people can access resources and self-navigate to some extent through evidence-based intervention. So here's some examples, and I'll start for that first rung. We developed an intervention called the mobile interventionist, and if you see that image, we're using a very simple flip phone. That's intentional, because the idea is to show that mobile health, digital mental health, can be deployed even with very unsophisticated mobile technologies. But the idea with this approach is that we would train a person to serve as a mobile interventionist, usually a community-based case manager, that would conduct a visit with a patient with serious mental illness, people with schizophrenia, schizoaffective disorder, bipolar disorder, that they would identify through a conversation what are the most viable treatment targets for that individual. And from that point on, they would start receiving daily text messages from that mobile interventionist to create this ping-ponging asynchronous conversation. By asynchronous, meaning the mobile interventionist might text them an opening message in the morning, might take a few hours, in some cases even a few days for the person to respond, so that while the conversation is not happening in real time, it's continuous. They can keep doing this over days, and in the case of this intervention, over weeks at a time. The information gathered by the mobile interventionist was also shared with their clinical team. And so even when they did meet with in-person providers, those providers had some more information from the mobile interventionist about what the individual was going through the week when they hadn't seen them in a while. And so a concrete example for how something might look, or text from one of our trials, a message might start with, "Hi, it's Sarah. How are you feeling, Ray?" And Ray responds with, "Hi, Sarah, voices talking about me." And Ray's referring to auditory hallucinations here. He's an individual with schizoaffective disorder that had a long history of hearing voices. So Sarah seizes the opportunity and delivers interventions. That's stressful, but you're not alone. Lots of people hear voices, Ray. And Ray responds with, "Voices say something bad will happen to me." I'm paraphrasing. The actual message was, "Voices say something bad if I take the bus." So now Ray is also providing Sarah with a specific environment where he experiences voices in a more threatening way than others. That's a very clear target, Sarah, right? And so Sarah astutely responds with, "I have a trick that can help you feel calm even when voices are loud on the bus. Do you want to hear about it?" Maybe. What is it, right? But that semi-enthusiastic response from Ray, that's the window of opportunity for Sarah to intervene, which she did. She trained him on how to use relaxation strategies, and at some point it actually translated to Sarah working in real time while Ray was on the bus, texting back and forth, and eventually working through his fear, which later we discovered that Ray was convinced that the bus driver was trying to poison, right? Which was clearly linked with his experience of his psychiatric illness. So when we delivered this intervention, we were very interested in seeing, can you even establish a therapeutic relationship with someone or a therapeutic alliance entirely via text messages? And so we administered a valid measure of working alliance called the Working Alliance Inventory to the patients engaged in the study. We asked them to rate their in-person providers and their mobile interventionists, the texting interventionists that they only met once, but from that point on had a months-long relationship entirely via messaging. And our participants provided good ratings for both of them, the ratings of their therapeutic relationship with their texting interventionist were significantly better than what they rated for their in-person clinical team, which in some cases they had been seeing for months and even years. When we conducted a randomized control trial of this study with people with schizophrenia, schizoaffective disorder, and major depressive disorder, these were people who had average lifetime psychiatric hospitalizations of 3 times, so certainly not a particularly high-functioning group. They were all getting assertive community treatment care and were middle-aged, not necessarily technologically savvy. And we found that the group with the blue columns, those are the people in the mHealth arm, the mobile interventionist arm. We found that there was a reduction in their persecutory ideation or paranoid thoughts over the course of intervention, while the group in the control arm experienced actual increases in persecutory ideation over time. And keep in mind, these are people who were identified as high risk for rehospitalization to begin with, so it's not surprising that they might have experienced illness exacerbation. We saw a similar pattern when it came to their depression ratings, a small reduction in their depression when they were getting the mHealth augmented support, but over time, the depression in the treatment as usual arm increased, so they were doing worse. And when we see their illness management and recovery ratings, more or less stable, a slight reduction in the mHealth intervention, but their recovery over time deteriorated in the treatment as usual arm. And so if anything, we see that the mobile interventionist texting approach served as a bit of a stabilizing function for people who were actually prone for relapse. Okay. I'll pause here for a moment and I'll just keep the screen up for a while because I think for people who are interested in clinical texting, these are very good reviews and I encourage you to read summarizing the state of the field. And there's a lot more literature coming out daily. Okay, from there to slightly more sophisticated technologies, this is when we move into sensing, natural language processing, and signal detection. And so most of you are going to be smartphone owners, and if you look at your smartphone, it gives us the ability to be a very versatile data collection tool. And so we can administer self-reports, just like I did way in the day back in my dissertation, but we can also track app use, call information, so frequency of receiving calls and making calls and the length of those calls and SMS or texting traffic, but also leveraging the host of sensors that are in smartphones like GPS and camera and microphone and accelerometers, all to collect data in a continuous manner. That data can be sent, assuming that there is reasonable connectivity, to remote servers, and they're processed, and we can see, this all enables clinician-facing or research team-facing fully remote monitoring. And so we can see what the person is thinking, feeling, and doing based on their digital indicators remotely close to real time. So what does that mean? We can ask people to provide audio diaries and apply natural language processing to those diaries. And we found that we can give pretty good indicators of their level of coherence based on features that are extracted from open audio diaries. We can apply the same NLP strategies and flag things like thought distortions, right? So indications of when they might be jumping to conclusions or catastrophizing based on their text messages. We can repurpose the GPS to determine their geospatial activity throughout the day. And so that might mean the distance that they cover through a particular day, or even the time that they spent at a particular location, right? Are they home? Are at the outpatient clinic? When they're indoor, we've run studies where we might place Bluetooth beacons on a hospital ward and see as the signal from one beacon to another changes, the strength of the signal gives us an indication of where the person is moving through an indoor space. And we can try to associate that to certain beliefs that they might have, or maybe risk that they might pose if they are in a forensic inpatient unit. We can use the accelerometers that are based in the device to determine with a pretty high reliability whether a person is walking or running or cycling but more importantly, the proportion of sedentary time, which we know is often closely related to mental health, either as a precursor to mental health problems or as a consequence where people become less active. We have speech detection software. We'll spark up the microphone every few minutes and capture ambient sound. The speech detection software can help us determine the conversation frequency or the conversation duration that a person is engaged in, and all in a privacy-preserving manner, meaning we don't actually collect the spoken word. The analytics are run on the device, giving us indications of the time in a conversation and the number of conversations throughout a day. Combinations of these sensors, we can also help get pretty good inferences of the amount of time that an individual is sleeping throughout the night. And we've actually published studies where we show that we can demonstrate that people are experiencing sleep difficulties based on their online digital traces, right? Because we know that we might not know exactly what it is that you're doing online, but of course, through authorization and a partnership with the clinical team, we can determine that someone is awake because they're online, playing games or using apps or doing searches. So conceptually, what are we trying to do with all this data collection? Well, we collect a host of these sensor streams, and it's a mess, right? I mean, when you have this amount of data, terabytes and terabytes and terabytes of data, it's difficult to try to make sense of it, and the modeling is a real challenge. But what we're really looking for are these meaningful events, the moment that someone is not doing well, right? The treatment target, which might be something like a hospitalization. And then we try to look at the data for that individual preceding that event. That might be that individual's unique relapse signature or illness exacerbation signature. Now that we have that, we can calibrate a model to search, not blindly, but to search for that unique pattern of sleep, of activity, of geospatial activity, of physical activity, of text message traffic. And now we're not hunting blind, but our system starts looking for those patterns within an individual. And the next time that we find something that's similar, that's when we raise the red flag. We're much less passive at this stage. And so raising the red flag might be to communicate to the individual, to the research participant directly, with feedback and encouragement to either reach their provider or to explore whether they've been taking their medication, or to their clinical team to prompt them to say, if you haven't been in touch with this participant for a while, their digital patterns seem to be similar to what occurred in the weeks preceding the last time that they had some trouble, that they wound up in the hospital. So if ever there was a time to conduct a home visit, now might be a good time to do that. Okay, we were able to run, like I said, the modeling is the real trick with this. And so through various forms of sophisticated modeling, we're able to demonstrate that using passively collected data, we can predict and determine when someone is more likely to experience a psychotic relapse. And of course, if you can identify something just in time, you can potentially intervene and prevent just in time, right? That's the next horizon for this work. Just like for texting, here are a few systematic reviews that talk about this field, and I'll leave that up there for a moment. Of course, we'll make these slides available as well later on. And from there to the last frontier, which is closely related to the type of activity that we're now also doing in Ghana, and that's where we have these automated interventions. And I'll tell you very briefly about a smartphone intervention called Focus that we developed for people with serious mental illness. And Focus is really a product of years and years of research. It started with Palm pilots and led to texting interventions. And as the smartphone capabilities evolved over time, so did the Focus program. And so we did usability testing with people with serious mental illness and their providers and their family members to get feedback on the things that people really need help with the most. We integrated audio and video resources into it. And so the intention of Focus is to be as close to a therapist in your pocket as we can bring the technology. And so How does Focus work? Once it's installed on a smartphone, it'll prompt the individual up to three times a day. But all the information is also available for people on demand 24/7 once they install the app. It's all on the app, and there's no need for internet connectivity beyond that point. It has 5 treatment targets. So voices or coping with auditory hallucinations, super common symptom of psychosis. Social functioning, which really means social skills training or coping with paranoid ideation. Medication use, sleep difficulty, or mood. Mood really means depression or anxiety. And so the way that it works is Focus will prompt the individual to engage with them multiple times throughout the day. And if they say that they want to do that, it'll launch into an assessment of whatever that individual and their provider decided is the most relevant area for them to work on. So in this case, Rachel hears voices, and Focus will ask, have you been bothered by voices today? Using multiple choice response options. If Rachel says, I've been moderately bothered by voices, Focus now launches into an assessment of her cognition, the distortions that she might have about those voices, using common options from the literature. And so how would you describe the voices? They can't be controlled, they know everything, they are powerful, they are unpleasant, or something else. And in this case, Rachel endorses that she thinks that the voices know everything, and now quickly Focus intervenes, either in the form of written text or in a video. So I'll provide an example for both. Here are the simple, easy to use, unidirectional written texts. Voices may sound like they know everything, but they don't. Can you think of any time when the voices made a mistake? How about when the voices were sure something was going to happen, but it didn't? If the voices got it wrong once, they probably don't know everything, right? Think about it. So the idea is to give the person skills to help challenge the validity of the voices, the power that the voices might have over them, and on and on. And so if they choose the video option, what they might get is something like this.
Voices make mistakes all the time. Try this experiment to test your voices. Ask them to make a prediction about the color of the next 3 cars that you see in the street. Write down the colors and the order that the voices say. Now, test it. Are the next 3 cars exactly in the same order of colors that they mentioned? If they got it wrong, think about it. What else could the voices be getting wrong? Their predictions are not always right.
So it's the kind of intervention that we might try to train someone in a session to use for themselves, but we really try to capitalize on things that might be in their immediate environment, right? Building on the fact that they're using a mobile device. Their responses to the assessment questions, they are all uploaded to the clinician dashboard. And so we have a snapshot of their own ratings of the severity of their symptoms, of their medication use. And of course, this gives the clinical team lots of options to identify when someone might be in need of more care. Okay, I'll briefly just provide some data on the effectiveness of this. So when we conducted a comparative effectiveness trial, putting Focus toe-to-toe with a clinic-based group intervention called WRAP, we found that there was no difference in the clinical outcomes. People in both groups improved significantly, but with the same magnitude of change across these groups. Most telling was that when we commenced treatment, we found that when people were told that they're going to have a mobile intervention, that's the blue column, even before they saw that 90% of them wanted to proceed with care because they didn't have to come into the clinic, right? They were able to get the app on their phone, and 90% of them actually started care when they were randomized to that. Whereas when it came to the group intervention, when we told people that they need to come into a clinic and be in a waiting room and meet with other people as part of the group, we lost close to half of our intended audience right then and there, who never, from that point on, who never made it back in for a single session. And so that's a really important point. It's not so much about the Focus intervention itself so much as digital or mHealth, meaning that the modality here made all the difference regarding whether people were actually going to come into care and be exposed to treatment content versus drop out right then and there. In terms of effects on depression, we saw similar impact on depression, even though the modality is dramatically different, right? One is entirely remote, largely self-driven on a smartphone, and the other one involves in-person with 2 facilitators at a clinic once a week session. When it came to effects on depression symptoms, we saw no difference across people that had severe that had psychotic symptoms, that had antidepressant medication use, independent of diagnosis. The effects of focus on depression were similar across groups. We, of course, saw a difference in people who had minimal and mild depression versus people with moderate or severe depression. The effects in people with moderate to severe depression were greater. And of course, that makes sense. When you're more depressed to begin with, there's more room for change. Recovery scores, similar in both arms, both improved in their recovery over time to the same extent. Satisfaction ratings, practically identical for both modalities, even though, again, they are dramatically different. And even when it came to cost, we saw huge advantages to mobile health, right? When we tried to monetize all the technology and the human support and everything that needed to be used to pay for this versus the cost of in-person care, meaning salaries for 2 facilitators, a space and a sofa to conduct care, and rent, we found that the cost of mHealth in this case, even though it produced the same clinical effect as in-person group care, the cost was quite literally half the cost of in-person services to produce the same clinical outcomes. Okay, so hopefully I've convinced you about the potential, about a range of digital health approaches in different clinical scenarios. Here's another informative slide with systematic reviews that summarize the use of apps in mental health care. And from here, I'll transition to our second speaker, because as we've been developing all this work in the United States and a lot of studies in Washington State and beyond, in parallel, we've been partnering with groups throughout the world to try to affect the state of mental health care globally. And that's when my partnership with Angela Ofori-Atta and the terrific team at UG kicked in. I will stop sharing slides here, and I'll transition over to Angela, who will take over.
Hi. Whoa, that's a tough act to follow, Dror. Great presentation. Thank you very much. So I'm minding my own business. How many years ago, Dror? 5, 6 years ago? And Dror calls and says, can we collaborate? And it's been a great collaboration since. I'm very, very pleased about that. So my presentation is about opportunities for digital mental health in Ghana. Anna, we can go on to the next slide. There we go. And the way I hope to make a case for digital mental health in Ghana is to talk about the prevalence of mental illness in the sub-region, and talk about the scale of the gap in service provision, which is the basis for needing to embrace digital mental health. I also want to talk about some evidence that solutions work, and that it's important to attempt these solutions and not leave things to chance. I'll talk about some digital interventions on the continent, and they're more from a public health perspective than they are from the patient individual care that Dror describes. And I'm hoping that in some of the work we want to do together with some of you listening, that we will also drill down to the individual interventions. And then I'll talk about our digital app, which we're testing right now, and where else we could go with digital mental health. So let's talk about prevalence. Let's talk epidemiology of mental health. Many of you know that there are about 30.8 million Ghanaians living in Ghana. But given the epidemiology given by the Ghana Statistical Services, about 13% of us suffer various forms and degrees of mental disorder. As well, we have a treatment gap, which is estimated between 95 and 97%. But I think given the strides we have made in recent years, we might think perhaps that the gap is shrinking to about 90 to 93%. The years of living lost to disability from mental illness is comparable with those lost to parasitic and infectious diseases, sometimes even more. So let's talk about child and adolescent mental health in Africa. So we're broadening the scope now, but the numbers are huge. We have nearly 37 million adolescents living with a mental disorder in Africa. Suicide is the 9th most common cause of death among adolescents aged 15 to 19. We have anxiety and depression accounting for almost 50% of the mental disorders among adolescents in Africa. And we have 1 in 7 children experiencing significant psychological hardship. And 50% of mental health conditions start by age 14 and 75% by the mid-20s. And then they're carried into adolescence, these symptoms. In our part of the world, then, the things that put people at risk for mental disorder are things like structural inequalities, such as educational and health systems, socioeconomic status, and so on. We have poverty, we have discrimination, we have domestic violence, we have effects of climate change, we have HIV infections, adolescent pregnancies, we have humanitarian emergencies such as war, floods, and conflict. These are general risk factors for mental illness. And if we do nothing about it, if we don't begin to think solutions, the number put out for Africa is about $30.3 billion in costs. The estimate is based on the value of lost mental capital or cognitive and emotional resources that children and young people would contribute to economies if they were not thwarted by mental health conditions. And in Ghana, we have a study that tells us that we have lost productivity to the tune of about 7% of our GDP if we do nothing. So what would investing in care yield? If we invested in mental health care, for every dollar we invested over 80 years, we would yield 21 times over the next 80 years per year. And so that tells, and we know that most African countries allocate less than 1% of their healthcare spending to mental health, compared to between 6 and 12% in the West. So let's talk about the gap in service provision. Now that we know what the numbers are and what it would cost us to do nothing, let's look at the gap in service provision. So the region has about 1.4 mental health workers per 100,000 people, compared to a global average of 9 per 100,000. The shortage extends to psychiatrists, hospital beds for mental illness patients, and coverage of outpatient facilities. So Liberia has only 1 practicing psychiatrist Niger has 3, Togo has 4, Benin 7, Sierra Leone has none. Ghana has more than 60, with almost 50 more in training. This is great. Unfortunately, post-COVID poaching of healthcare professionals by wealthier nations may further reduce the numbers of these highly trained cadres. Accessing care is limited by gaps in knowledge. For example, even if we had a full, how would you call it, slew of work, people may not access it for reasons of knowledge. So, for example, in Ethiopia, a community study showed that 45% had inadequate knowledge about mental health, 18% believed psychiatric disorders are contagious, and 33% considered living alone as a treatment for mental illness. And with regards to illness causation, 88% believed in possession by an evil spirit, 76% believed in illness as God's punishment, and 67% believed in witchcraft. The study revealed, however, an association between high education levels and better mental health knowledge, as we found in Ghana and in Nigeria. So we would need, one of the things that we really ought to be doing is sharing information. Typically, mental health care for adults in West Africa is commensurate with the belief systems that they share. So most are looking for a cure, as per our 2017 study in prayer camps. They said to us, we offer management in hospitals and outpatient departments. We tell them, take this medicine. It will help reduce your symptoms, but you have to keep taking it. But they're looking for miracles. So they go off to the prayer camps, and in their hospitals, there is relatively inexpensive, in the prayer camps, there's relatively little to pay upfront. And perhaps because of the belief system, they feel less stigmatized than the care they receive from psychiatric hospitals. In faith healing camps, however, the infrastructure is poor, and so restraints are physical. It's the use of chains or shackles, human rights abuses. Family members often go away, leaving patients in these camps for long periods of time. Food is scarce, there's little upkeep, leading to forced fasts, dangerous levels of malnutrition we're finding in some of the prayer camps we work in. And in the residual phases typical of serious mental illness, there may be a conclusion that there's been a cure, and relatives are contacted to take the patient home. A cure is announced until the active phase of illness returns and the cycle repeats itself. So we actually have more faith healing camps, maybe more than 1,700 of them. Many of them are residential, but many are also non-residential since COVID. We have orphanages and special schools for children. We have psychiatric hospitals, like 3 large ones. We have district psychiatric units that have 10 to 20 beds. We have community psychiatric care services in over 2/3 of the districts nationally. And we have some counseling units in schools and universities. But this is not nearly enough for the numbers that need the care, the 90% that don't get the care that they need. So let's look at some evidence that solutions lead to to good results. Let's look at a particular study that looked at 64 articles, which encompass about 57 unique mental health interventions involving over 40,000 adolescents. Some of them were economic-based interventions, some of them were psychoeducational approaches, and these were across different settings, school settings, community settings, home settings. And notably, half of the interventions were delivered by laypersons. And 55 out of the 64 articles reported positive and significant impacts on various mental health outcomes. This is great news. One such intervention to look at is depression, looking at an intervention for depression, group interpersonal psychotherapy, 8 to 12 sessions for women, which shows across different settings that 80% of women treated remain depression-free 6 months after the therapy ends. And it's not just the women who are symptom-free, but they work better, their meals eaten in their households go up, the school attendance of their children goes up, and at least 4 members of their households are impacted by them getting better. So this is a great case for doing things and for giving some care for people with mental health problems. And there are a number of ongoing solutions to close the gaps in Ghana. And I'll very quickly go through. For example, in the 2000s, we embarked on task shifting. And, we set up the Psych Corps, which are university graduates doing their national service and working with community psychiatric nurses to provide psychological first aid in the districts. And Basic Needs is an NGO which goes about, provides care in community settings and skills training programs as well. Then there are peer counselors in universities and in high school settings. So I'm deliberately going through these because as I'm going through them, I want you to think digital. How can we bring digital stuff into these situations that exist? Okay, can we go back for a little bit? Thank you. So mobilizing resources, for example, to give donor support, mobilizing resource to fund these kinds of interventions done at the community level, incorporating mental health care into the criminal justice system for offenders, and therefore bringing in lay counselors into the criminal justice system. Awareness creation through videos, films, on social and traditional media, integration between traditional practices and general health services. Imagine the Ghana Health Service bringing in traditional healers, and going digital with all of these ongoing solutions. So let's leapfrog the service gap by going digital. And let's see what we can do with these digital interventions right here in our sub-region. So to this, we turn to a Nigerian by the name of Adepoju, who wrote a very nice article in 2020. In this article, he talks about countries in Africa like Nigeria, Ghana, South Africa, and Kenya having telecommunications density exceeding 100%. So each person has more than one mobile phone, for example. Mobile telephone connections in sub-Saharan Africa will increase from 816 million to 1.05 billion in 2025. making technology-based services a viable option to clear the mental health backlog. And we don't have to wait till 2025. We're already there. And Depuju talks about some of the innovations that have sprung up during the pandemic. Wazi in Kenya, which is a virtual platform for therapy. SINDAP in Nigeria, which helps you find a therapist near you. Mind It from our own University of Ghana medical student and his brother set up a referral system on telephone. And mHealer, which is our app for teaching psychosocial interventions in Ghana, and talk about it in a minute. Then there's a mega project in South Africa and Zambia that are joining local and national associations of psychiatrists, providing free virtual online mental health consultations. And then as a result of this, they've increased or scaled their offerings 50 times to 175 times the number of patients they see by doing telehealth. Our digital intervention, then, I am very pleased to present, is called mHealer. But before I go there, I want to talk about the first intervention that we want to do is building partnerships over a digital platform. So we want to form what we call the West Africa Digital Mental Health Alliance. Doesn't it sound grand? And it focuses on collaboration for development, research, onboarding, and monitoring of digital apps. And we want to include on this digital platform policymakers, researchers, academics, and end users. And it is very key to include all of these people, because then we will know in which directions to go. And we're hoping many of you will join the digital partnership. And this is what Dr. Kola talked about at the beginning. The second of our digital interventions is combining mHealth and nurse-delivered care to improve the outcomes of people with serious mental illness in West Africa. And let me introduce you to our great teacher on the app. That's him on the right there. And mHealer is a mobile health program designed to train healers to deliver evidence-based psychosocial interventions while maintaining safety and patient dignity in practice. And the second intervention in tandem with mHealer is visiting nurses who directly deliver pharmacotherapy to the patients at their prayer camps. Now, this is what the interface of mHealer looks like. If you look on the left, you'll see the modules there. The dove looks peaceful, and there's relaxation skills training on there. There's other skills in the human rights and so on. And then a really nice feature is the patient's feature, where the healer can begin to track his or her patients over time and actually use emojis to show whether the patients are doing well or not. And then, of course, if you look in the middle, this last interface here, you'll see something about human rights and a patient chained to a tree and so on. But mHealer is designed with collaboration from healers in Ghana. It's aimed to teach evidence-based psychosocial interventions and other helpful skills. It's a tool for healers to use to supplement their current treatment, and it's available in both Cree and English, Cree being our most widely spoken local language. And we've done our optimization phase, which is a pre-trial intervention or a pilot study, where we had 4 healers receive a device with mHealer on it we had 15 participants complete an 8-week intervention cycle. So over a 2-month recruitment period, we had about 82% of our patients with schizophrenia, 12% with bipolar disorder, and 6% with major depressive disorder. And we measured these outcomes, these psychiatric outcomes, psychological distress, shame, and days chained. Okay, so I'd like you to concentrate on the rows where we have the green arrows, and these are the variables that changed significantly over the course of the 2-month trial. I think we can go to the next slide because I've summarized it. The psychiatric symptoms measured with 2 different measures showed clinical improvement. The psychological distress went down. The level of shame reported by patients went down significantly. These all have clinical significance. And the number of days chained literally halved with the use of this mHealer intervention and medication. And the degree of stigma towards self also reduced significantly. And these are really important measures of mental health. So then we just felt very confident that we could go into our trial. And so far, it's a step-wedged randomized cluster trial. And what it is, we've already passed 90 patients through the first 8-month period of the study. We're moving into the second phase where 6 of the camps, the prayer camps, will receive the M&M intervention, which is the mobile nurse and the mHealer intervention together. And we're very excited about what the outcomes are going to be like. So in a nutshell, this stuff works even in the most difficult of conditions, such as very rustic prayer camps. Now, there are other opportunities for digital mental health, such as we learned from COVID digital health in general, apps for information sharing, call centers, triaging apps, referrals, the use of Twitter even for location services to send people to centers close to them, the use of Bluetooth devices to inform about COVID-19 contacts, chat boxes, telemedicine, and so on. So we already have this in digital health in the sub-region. How do we get it into mental health? There are apps like mHealer, which teach, for example, faith healers, tested psychosocial interventions. And we can extend these to patients themselves and patient families. And we can follow up patients after discharge from hospitals and keep them close to us. Apps to provide students in universities with solutions for mild to moderate mental health challenges, like Prof. Kaufman and her students have developed, which we might help to test on WADMA, on the WADMA platform. The use of learning information systems such as Teams, because we have Teams in the University of Ghana, we have Teams in the University of Washington and other universities. Use them to improve access to psychoeducation, regular meetings, and so on. Awareness creation through websites, apps, chat boxes, apps created with modules in CBT, like Dror said, common mental health challenges such as sleep disturbances, which we can help with on the apps. And there are all kinds of online courses we could structure for the university, which are non-credit, but which will help students begin to take care of their mental health better. Several tech platforms being developed for provision of psychotherapy online, apps which help in finding the nearest mental health services, more avenues for telemedicine, and creating apps for special needs such as suicidality, sexual abuse, rape victims, with inbuilt referral systems that take away the shame and enable people to access care. So, in sum and in conclusion, the provision of mental health services, there are opportunities for digital mental health, which exist in the provision of mental health services via apps and websites for the general population. There's a provision of knowledge. We need to provide knowledge through websites in local languages, on videos and audios, patients, families, service providers. The provision of media content for movies, social media, adding the human touch, for example, the psych core, peer counselors who will then create the awareness that the apps exist and help people onboard them onto the apps. The creation and use of new digital ways to detect change in movement patterns as relapses occur, like Dror talked about, and apps which help patient self-management through periods of crisis and so on and so on. The sky is the limit. So I hope that this brings home to you that we already can begin with what we have. And we're just looking for a very vibrant community that's going into digital mental health. Thank you.